and mute your thing. All right, so again, welcome everybody. Thank you for joining us. I just first and foremost want to wish everybody healthy and safety in these kind of unusual times. And I think the one thing that's good that's come out of it is to be able to do some of these webinars and get people together. Hopefully this will be enjoyable. I will tell you that you're not going to feel like you're going to be a perfect expert when this is all said and done, but I'm going to try to make you a little bit better. I want to start off by thanking my team for helping us do this. Certainly Dr. Martin for organizing a lot of this, and also Jess Colantuno, Kelly Friedman, and Ashley Duff for all the things that they can do. Dr. Martin, can you see my cursor when I'm going to just nod your head if you can see my cursor? Okay, thank you. Okay. So the goal of this presentation is to, it may be a little bit shock value, but for the most part, I want you guys to be able to recognize when there's an emergent situation. I don't expect you to make diagnoses, and I don't expect people to be able to, cure the conditions. It really is to kind of give you an idea of honing your powers of observation. I think one of the things that I expect a lot of our owners, clients, grooms, trainers, et cetera, I do have certain things that I expect them to at least be aware of and know what's out there. And then I expect the other ones who are just going to say, well, I don't know what's going on. We need to talk to the veterinarian. So the first thing that we'll go through is the very basics on doing physical examination. And then I grabbed 6 different conditions, probably the more common of the emergency conditions that we see with our horses that I pulled together. I don't typically put eyes in my lectures. People that have heard me speak in the past find I don't put them in because people tend to get a bit queasy with those. The fact this is on a webinar, I won't know if you're queasy or not, so I'm less concerned about it. I will let you know when there's going to be gory portions. When we get into the lacerations, they're a little bit, there are some blood pictures, so I'll forewarn you when we get to those. So in starting with this, and a lot of this is common sense, but recognize us as veterinarians, we're trained to be involved in these kind of unique and exciting and stressful situations. And I will admit that when we first come out of school, we're not ready for it, just like you're not expected to be ready for it. And you have to kind of train yourself and experience these time and time again to start becoming more calm. So the only suggestion I can give most people is try to remain calm, assess the situation, try to communicate when you're calling us on the phone. People don't realize that they basically throw out a whole line of verbal diarrhea to the veterinarian and we never even understand a word of what was said. And then they hang up before they even tell us where they're located. So sometimes you got to take a breath, step back, see what the situation is, speak clearly with us the best you can. And you're going to hopefully provide some assistance to the animal, but also if you're helping another individual in this situation, maybe some assistance there. And you guys are on this talk, so you're obviously interested in educating yourself. Certainly education experience is going to help, and certainly common sense is really what a lot of this is focused on. So let's be honest, horses do dumb things. This has to be a male horse. There's only a male would actually expect that they think they could clear this gate and not quite do it. Actually, this horse was perfectly fine, but you could see where things could go very south otherwise. So let's start with the physical examination. And to know what's abnormal, you have to look at a lot of normals. And you guys are at a lot of different barns and have horses at your disposal. And you should start, again, honing your observational skills to see what things look normal, what things look different. And every horse has something wrong or different with them. And it really is helpful to start really focusing on that. So what do I expect? I expect a lot of my horse owners to be able to at least give me a heart rate, respiratory rate. Rectal temperature is a necessity for us. Gut sounds, that one's sometimes a little more difficult for people, and lameness. Now, when we talk about lameness, I'm not talking about the lameness that you see some of us do when we're dealing with performance horses. They may be more subtle lamenesses, lower grade, and we usually evaluate those guys at the trot. These lamenesses I'm talking about in the emergency situations, these are done at the walk. And it really doesn't matter if is it serious or is it not, okay? And I think I've already commented that we're going to work on your observational skills throughout this. So I think you guys can all see, I mean, people always ask me, well, what's a normal heart rate for a horse? The different size of the horse in terms of what breed they are can vary, but in general, our warm bloods, our thoroughbreds, their heart rate's going to be in the 40 beats per minute. And I encourage a lot of my clients to buy a stethoscope. There can be actually some very cheap ones out there that you can, oops, sorry about that. My bad. There can actually be some very cheap ones out there. I've seen them as cheap as 10, 15 bucks. You know, they're not the best quality, but, you know, really it takes a little bit of help, and some people can help guide you, whether it's the veterinarian or other people are used to using it. But we actually go and listen to this area on the left side of the chest. Primarily, you can do the same area on the right side of the chest to hear the heart rate. And you should do it before you're in the emergency situation, so you know what normal versus abnormal is and how to hear it, because it is different. And typically whenever you put a stethoscope in your ear and you're trying to listen, somebody will start talking to you. So it always makes it a little bit more challenging to hear when people are talking to you in there. So heart rate, oh, I should have started by saying, you know, when we're looking at heart rate and respiratory rate, some of those things, some of those indications are telling us about pain in the horse. When a horse has some type of painful incident, heart rate and respiratory rate will typically go up. Temperature does not always go up. Temperature is a little bit more of an indication of infection. Well, let's go to the respiratory rate. We usually are looking at about 12 breaths per minute on a horse. And to give you an idea where the lung field, we've outlined it here in green. You can see this area. Now, I'm not necessarily concerned or want the horse owner to be able to tell me what the lungs sound like, because when you put a stethoscope to this area in a normal horse, it shouldn't sound like anything. You don't even hear air go through it. That's what a normal lung should sound like. But abnormal lungs have other sounds. For me, I'm really want a horse owner to tell me what's the rate. And you can figure that out by, you know, maybe going and looking at their flaring of their nostrils, or when they inhale and the chest expands, usually the abdomen kind of expands as well. And you can kind of see their flank raise and lower. And that's usually a nice way of getting a respiratory rate. So again, the normal respiratory rate should be about 12 in a horse. When they're painful, both heart rate and respiratory rate typically go up. Rectal temperature is a necessity that we expect a lot of our clients to be able to get. Unfortunately, we do have to do them rectally. And in these cases, with the rectal thermometer, I always would give my students when I was at the college a digital, or not a digital, a glass one, so to watch them struggle, because most of the younger individuals in the audience don't know how to read these. Many of them are used to the digital thermometers, which I have no problem with digital thermometers. This is a brand that I really actually like quite a bit. And it's a little more expensive, but you get a readout in like literally seconds with this thermometer. But I'm not necessarily endorsing Vicks. I just happen to like it myself. The normal temperature for a horse, like in the current Northeast now that this is April, May, we're in actually now, basically we're looking at probably the 100 range. You know, if we start getting up into the high 101s, lower 102s, that's not normal. So there's usually a reason for that. Okay, so these are some of the things that we expect our horse owners to be able to provide us. Now, again, I think part of this is honing your powers of observation, and maybe this is not all that, or this is obvious, but the horse on the left, her name's Betty Boop, and you know, when you approach her, she is very inquisitive. She puts her ears up at you. She's looking at you, and horses are very inquisitive species, and they do want to do that. If you look at the horse on the right now, mind you, he's a little disheveled. He's been rolling around, but he's kind of got a glassy-eyed look to him there, maybe a little bit, you know, maybe a little bit depressed with it. Hopefully everybody can appreciate that this is not normal. This happens to be a younger horse with a case of strangles infection, and these are swollen jaw from infection of some lymph nodes in that area. But look, I don't expect anybody to give me that diagnosis. That's for a veterinarian to do. I expect you to say, hey, this is not normal. Betty Boop and this horse look very different. This horse is actually a horse in the clinic, and again, it's less about the diagnosis, but more, hopefully everybody looking at this horse would notice that this ear is drooping down. His eyelid is drooping, and if you look in the top right, you'll see the eyelid is very droopy. Those that are a little more astute will notice that the cornea itself is very cloudy. If you look at this horse's nose, it looks like he's wrinkling his nose, and when you look at it a little more close, you'll see that it's actually being pulled to the right, and that's not normal. Now, this horse isn't actually experiencing any pain. This is actually a neurologic condition that's creating an ear paralysis, an eye paralysis, and a facial paralysis on this horse. And again, really the goal here is for somebody to say, hey, doc, this is not normal. Why is this? All right, so now the next thing in our physical exam is listening for gut sounds. I don't recommend putting your ear to a horse's flank. Some are very sensitive in that area, so avoid that temptation. In general, we should hear their stomach gurgling every 1 minute, one sound per 30 seconds to a minute. Horses that are going to develop or are developing diarrhea will sound like a washing machine in there. Other horses that are in colic scenarios, they may have very depressed gut sounds. And we put them into quadrants. This is the top left and the bottom left, and we listen to the same on the other side. And each of those quadrants sound a little bit differently. Again, probably more for a veterinarian. If you just hear some gut sounds, that's what we're going for. And so this is obviously very important when we're looking at these colic scenarios. And I think that's my next slide here. We're talking about the colic situation. Now, colic's a term that we use incorrectly because it's not a disease. In other words, it's not a diagnosis. It's actually just a symptom of some type of pain or discomfort, typically in the abdomen. We often think of it to be intestinal, but it can happen from any other condition. Pain in the uterus, pain in liver, pain in kidneys, bladder, they can all show up as colic symptoms. So this is a still image. Some of you have seen this picture before. This horse is, obviously uncomfortable. You can see that she's kicking up at her belly. She's in a weird stretched out posture up front. Her head and neck is in an abnormal position. She's not sedated. This is just her. She was clearly rolling. She had a blanket on, and this is the clean area, and everything else is just filled with mud. So she's clearly not comfortable with that. And again, I don't know what the diagnosis is here. I just know that she's experiencing discomfort. For this talk, I took a bunch of videos. There you go. That off of YouTube, which I found it to be nice. There's some things I like and dislike about it, but just to show you a horse that's colicking, I don't have a lot of video footage of this. And, you could say, well, maybe this horse is sunbathing or getting a dust bath. But if you notice that this horse is just not getting comfortable, he's flank watching, his abdomen is a little bit distended, but he just never seems to get into a comfortable spot. And he just, he's clearly experiencing some type of discomfort with it. So this, again, is a sign of colic. Now, in the more severe painful scenarios, these horses tend to be very traumatic to themselves. And you can see by these two images, this horse has done a fair bit of abrasions above his eye. This horse similarly, just not as aggressively. And this is a sign of the severity of pain that these guys are experiencing. This horse actually is in a full sweat. She's actually on her way into the OR from here, but not all horses will beat themselves up quite like this, but when they do, it certainly gives us an indication of something a little bit more significant going on. The horse on the left actually had what was called a diaphragmatic hernia. Most of her small intestines were up in her chest cavity, and it actually was congenital. She was born with that for whatever reason that day. It snuck up into the chest cavity and it twisted off the intestines. This horse actually was fine after this. It just, he got loose in the stall aisle, which was concrete, and that's why he kind of banged himself up. He actually was colicking. He rolled out of the stall, believe it or not. He got underneath the stall gate, and that's why he beat the hell out of himself there a little bit. So what do I want from my horse owner in these cases? Well, I do think some horses weirdly will eat through pain, and I'm not sure why they do that. I like food just like the nest, but when I'm in pain, I don't feel comfortable with eating then. Maybe they're stress eaters. But I do ask people, for the most part, remove their hay and water unless we tell them otherwise. I think some people feel more comfortable getting them moving and walking. I think there's a value in that. I do think it stimulates some gut motility for them to move around. Some of the older horsemen, I shouldn't say older, seasoned horsemen, the idea of putting them on a trailer and bouncing them around on a dirt road to help move gas along for those gas colics. I don't think there's any harm in doing it. I'm not sure that you have to go into it with the idea that it's going to do a whole lot. If they truly have a twisted portion of intestine, bouncing them around all you want is not going to make a difference. But I don't want to discourage it in those scenarios when you're waiting for the vet and maybe you have limited finances. Maybe that's an option to try. I usually tell people, try to make them as comfortable as possible. I usually tell people get them out of the stall, especially if they're up, down, roll. You know, I usually say get them out of the stall, get them into an open area so they don't get cast, they don't get themselves caught on something. Take them in the indoor, outdoor, front yard, whatever will work. My attitude is if they want to lay there quietly, that's fine. I don't have a problem with them rolling. Like, I don't believe the rolling itself twists the colon or the intestines. I've seen horses not even lay down once and still twist those areas. On the flip side, I don't want them to keep rolling because I find they get cast and just the lead rope gets caught around things. So if they're wanting to be up, down, roll, then get them and just keep walking them. The majority of our gas colics should resolve in about 20 to 30 minutes. If not, then we have something more serious going on and it requires, you know, attention. Now, these two videos are going to roll, and I want to talk to you about what's in some of these videos, some things I like and dislike with it. But one of the things besides us rectaling the horse that we're going to do is we're also going to pass the stomach tube. And passing the stomach tube is going through the nose into their stomach, and it's for two reasons. It's one for diagnostic purposes, and it's for therapeutic purposes. Horses anatomically lack the ability to vomit. In other words, as the stomach fills up and we feel that bloated feeling, we have the ability to open the sphincter into our stomach and purge it out from our stomach. Horses don't have that ability, and if something's obstructing, they're filling up with fluid, the stomach will catastrophically rupture, and those horses typically die very quickly. So the image in the lower right is showing you a horse that has an obstruction and is developing a lot of reflux. In a minute, you're going to see a bunch of stuff coming out of the tube. Now, I have some very strong opinions but negatively about a twitch being placed on a horse's ear. The gentleman here is in flip-flops, which I have a problem with that too. I've kicked people out of their own barns that are wearing flip-flops around horses, but that's not what the purpose of this video is. And you can see all this reflux that's kind of coming out in that lower right-hand corner. You know, the video on the top left is a veterinarian that's administering water and electrolytes and doing it for more therapeutic purposes. There's probably mineral oil in that bucket as well. There's also some things I would probably question in terms of safety in this. And, you know, as veterinarians, we have to be very careful of the safety of ourselves, the handler, the horse, all those above. And this one in the lower right has a few challenges in it. All right, so I should have said, oh my goodness, I should have said from the very beginning, we're having some issues there. All right, everybody sees choke now, Jess? Okay. So unfortunately, with all these diseases I put in here, you're not going to feel like an expert on it. You're just going to get enough for a tasting, and that's all I'm going to talk about colic. All right, and I know that may disappoint you. It really was just to kind of give you a little bit of a taste. We could talk about each one of these diseases for an hour alone, and the goal here is to get you experience to kind of at least see what we should be expecting in some of these conditions. So now we're going to segue to choke, which can look like a colic. And just to declare or at least identify what choke is, I don't like the term personally, because when I think of choking, I think of people where they're talking about not being able to breathe. So I don't think it's the absolute right term, but it's what we're used to. Choke in a horse means that they have something caught in their esophagus. All right. Maybe you've experienced as well where you're eating and maybe you didn't chew as quickly or as much as you should have, and that whatever you swallowed is a little bit larger, and you kind of feel it go down your esophagus and kind of sits right in front of your stomach, and it will get kind of a spasm that feels a little uncomfortable. Well, horses can experience that as well, and that's what we see. Now, when it reaches that area and it completely obstructs that area, what happens then is the horse will create more saliva, swallow it, it hits that obstruction, and then they regurgitate that saliva and feed material back out, and it comes out their nostrils, not their mouth. It comes out their nostrils, and there's an anatomical reason that happens. So these two images, the image in the middle and the image on the left, is showing you the same horse with there's frothy saliva and feed material coming out both nostrils. In converse to the horse on the right, that's showing you discharge out of one nostril. I know you can't see the other one, but trust me. And what you're seeing come out of here is mucus or pus. And this horse actually has an infection going on. So two very different looks that you see here. Now, this video shows you a little bit some of the signs that you'll see with a horse that's choking. He's very agitated. Now, he actually coughs and brings out stuff out his mouth, which is not very typical. But this horse, I should go back 2 little slides there. He just is very agitated. You see stuff coming out his nostrils with it. Sometimes you'll see a little bit of feed material. And, yes, waiting for the veterinarian does feel like an eternity with these guys. So the big question is why do these horses choke? And these horses choke for several different reasons. Sorry, I'm trying to go to the next one. One of the first reasons, those of you that feed beet pulp. So some of the people that feed beet pulp, one of the things that beet pulp does is like a sponge. It absorbs moisture. So when the horse actually goes and swallows a dry beet pulp, saliva combines with it, and it actually goes and expands quite a bit more as it then gets caught in the esophagus. So beet pulp should be soaked well ahead of time before actually feeding. So I find some of the pelleted feeds that we feed will actually be dry and collect more moisture, and horses will choke on that. Some horses will bolt their food and just be ravenous eaters. And some horses have, they don't chew appropriately because of poor dentition or tooth-related issues. There's a host of other reasons why. I know a few people have raised their hands. If you would, send your questions to the question and answer section, and I will, and Dr. Martin will look at those and get an idea if I need to move on or answer those at the end. So when a horse owner is dealing with a horse with choke, what are we expecting? What is my expectations for that? First thing is I expect them to remove the hay and water. I don't try to feed them through it, because the one thing I don't want to happen is for that food or saliva or anything to then go into their trachea and aspirate into their lungs. So we really take away all their food and water. I usually, when the client calls me, it's going to happen almost immediately after they eat, usually within the first 5-10 minutes of them eating. And then what happens after that is we wind up asking people, I ask people, take them out of the stall, put them on cross ties, dim the lights, play music, groom them, basically try to calm them. You can sing them a song if that makes you feel better. The goal here is just to make them relax. I would say the large majority, probably over half of my chokes, will actually improve simply with just getting relaxed, and they'll pass it on their own. So I usually tell people, put them on the cross ties. I'm going to call you back in 15 minutes. If it resolves, then we're good. Otherwise, we'll go and come out and treat them. And unfortunately, or not unfortunately, but treating them a lot of times, what we have to do is pass a stomach tube, break up that obstruction, and pass a tube into the stomach. Sometimes we require other measures of surgery and endoscope. Do you have a question there, Jess? You're on mute, Jess.
Can you hear me?
I can now.
So Sarah Silkoch is asking, do you recommend massaging the throat for a choke, the owner, while they're waiting for you?
Yeah, it's a great question, Sarah. And I do think there's some value in that. If there is a bulge, it's usually on the left side of the neck. Sometimes that's helpful. I don't think you're going to cause any problem. Now, don't take a vice grip across it. I don't think there's a reason for that. But yeah, I think massaging is perfectly fine. Again, it's either going to resolve or it's not, and that's part of the challenge. I have stopped going immediately on the phone call and waiting about 15, 20 minutes, because half the time I drive halfway to the call and the client calls me back saying, I think they resolved it. So I usually am a little bit slower to rush out and just wait and see if they pass it on their own. And some horses know how to relax themselves, and they just need some time, and they'll pass it on their own. But time in this case is like 15, 20 minutes. We're not waiting 4 hours. If they're not passing it in 20, 30 minutes, it needs to be treated.
One other question, Jim is asking, for a choke, are you trying to keep their head up, down, or neutral, or does it matter?
I don't think it really matters. I don't think you should force them either way. Wherever they're comfortable, it's fine. Technically, by them putting their head and neck lower as they're bringing up stuff, it'll keep it probably less likely of them aspirating. I just am hoping to put them so that they can relax. And if some horses are used to being cross-tied, and they'll relax a bit more there. On the flip side, if you put them in the stall and then put their head down, then they may want to try to eat more. That's my only reason for not doing that.
And one more, what are your thoughts on lunging a horse during a choke? Yes or no?
don't think that helps as much. I wouldn't think that would help as much. I don't think that would be relaxing enough for them. Okay. All right.
Susan, I'm going to answer your question. I'll type an answer so you guys can read that, but I'm going to let Dr. Fugaro continue on.
Okay, great. So that's all we're going to talk about choke, and then we can answer more questions at the end. There will be time for that. So lameness, and I already expressed that lameness we're talking about today is done we're assessing them at the walk. So we want to make sure that there isn't something rather serious going on. Lameness in general tells us about the musculoskeletal system, meaning bones, muscles, skin, maybe not skin. Well, yeah, skin, joints, tendon sheaths, things like that. We're looking for signs of inflammation, and the hallmark signs for inflammation are heat, swelling, pulses, redness. Now, unfortunately, we don't see redness in horses, and people will see redness, particularly if we're Caucasian. But in our horses, because of the hair and the pigmentation, we don't really see redness as much in them. But we'll get an idea. Lacerations or some type of cut, they're initially sore especially when we're talking about just skin. If you have a skin cut, they're going to be sore in the initial phase, initial being maybe the first 15, 20 minutes. And then short of you keep touching it and creating more pain, they really shouldn't be that painful on it. So if you have a horse that's lame and it's just a skin cut, maybe it's not just a skin cut. All right, and I'll explain that in another couple slides here. So this is where experience and being involved in these kind of helps you out in understanding this. So if you look at these two rumps from the rear here, you see the horse on the right, you see a nice round butt here, and they're very symmetrical. The horse on the left is a brood mare, and hopefully you can appreciate she's got a relatively round butt here on the right side, but on the left side, you notice that she's kind of hollowed out. You have a significant amount of muscle atrophy, and this is very asymmetrical. This is actually a broodmare that had a pelvic fracture when she raced. This is several years after she was done racing. But again, honing your powers of observation, hopefully most people would say, hey, this is not normal, as opposed to this. Other things, I'm a big fan that I tell clients, when you see blood trickling down a leg or any type of cut, clip the hair, because you really don't know the extent of what the cut is underneath the hair. This looked like a little nothing abrasion, and this had potential to be in the joint. It actually wasn't, but it was much larger than we had expected. So this is a front of a fetlock that you're looking at. This is the front of a knee with a very large swelling here. And then this particular leg here, which is the cannon bone of a front leg. Hopefully everybody can appreciate this kind of bulging. And this is a bandage bow. This is actually a bowed tendon that occurred by somebody putting a wrap on. This horse was actually not lame, but again, observational skills. Now, both these horses, in these images, both horses, the head is facing the left and tail is to the right. You're looking at the inside of the hock in this left image, and on the right, you're looking at the outside of the front knee. I think everybody can appreciate, well, let me give you a depiction of what you would see with this horse. Both of these horses are severely lame. They don't want to put weight on it. Obviously, they're standing on it right now, but they don't want to put weight on it. They may have a fever. If you barely touch the skin, they'll go through the roof. They may not kick you, but they'll want to. Now, in this horse, you see that this horse actually has an abrasion here, a significant abrasion. You can't see so well here. There's another abrasion here. Both these horses are experiencing cellulitis episodes, and these can come on very acutely and very quickly. These horses are severely lame at the walk. And again, cellulitis is just a fancy term for an infection under the skin. These horses, you see the lower legs actually look very normal, and that's because we're a little photoshopped here. These are a day or two down the road, and these horses had wraps on the leg so that swelling was not going down the leg. On the first day, this whole leg is going to be swollen, and unless you wrap up above the knee and above the hock, it's very difficult to get this swelling to come down. All right, so again, something else, fever, lameness, pain to palpation on this. Okay, most of the lamenesses that we see are occurring from the fetlock lower, probably about 75% of them. And the number one lameness that we see that's acute, severe, horse non-weight bearing, probably the number one that we see on those is a foot abscess. We all jump to fracture. That's the first thing we all want to think about. We're worried about it. We know the catastrophic nature of fractures, but the truth of the matter is, in most veterinary practices, and most horse areas, the number of fractures you're going to see are very, very rare. But your horse, it doesn't matter how rare it is, it's still not fun. But a foot abscess is the number one thing. These horses are acutely and severely lame. There's typically no swelling because the foot doesn't expand. They have heat and pulses to this area. And I'm a firm believer, I think every horse owner, every trainer, every groom, you should own a pair of hoof testers and learn how to use them. It's not very challenging. I don't feel like it's practicing medicine. You're not taking away anything from anybody. They're just basically a glorified pair of pliers, for lack of a better term. And when you go squeezing these areas, and people ask me, how hard do you squeeze? And you have to learn what that means. I can't explain that verbally. You're just trying to see if there's an area of discomfort. And sometimes that can be from an abscess. It can be from a shoe pressing a weird way, a bruise, etc. And so I really think everybody should own a pair of these. Most of the people in the audience here have been around horses, but if you haven't, this is what an abscess looks like in the foot. This is a horse, once you remove the shoe, found a little bit of a defect here, and as you dug a little bit further with the knife, you get this nice pus that wants to drain out. The images in the top right, this is actually a farrier that was routinely trimming. This horse actually wasn't lame. He had this one discolored area. He asked me to come take a look at it, and then he made the next little swipe with the knife, and you can see all the pus coming out. Most often, well, I shouldn't say often, but a lot of times the pus that comes out is mixed with dirt and debris, so it comes out black like that. We typically treat them with betadine and Epsom salt soakings, and it's usually very, very helpful. This is a neat little video. It's not neat. I'm sure the horse is not all that comfortable, but this is depicting a horse that's pretty lame on his right front. And it'll show up here in the next minute here. You'll see he'll go to take a couple steps on his right front, and he's not wanting to go forward. When he does step on this, he'll kind of hop off of it very, very quickly. And I think it's not a real diagnostic challenge to figure out that he's lame on that right front. And then when you just look a little closer at the coronary band, you're actually seeing pus draining out, and this abscess, drained out the coronary band. And that's fortunate when you have these. Not all of them will do this, and some of them take a lot longer than others to reach this point. Now, I always tell people you should look under the bottom of the foot before you call the veterinarian, because sometimes it's obvious as to what's going on. You didn't necessarily need an x-ray to diagnose that this horse stepped on a nail. Now, what's weird about my statement here is I'm going to ask you, if you do have a horse that stepped on a nail, call a veterinarian immediately, and do not, I said it 3 times, do not pull the nail out, okay? Because there are a few structures we want to go and make sure this nail didn't hit. Keeping the nail in is helpful. Now, if we can't get there for an hour or so, I'm not going to leave the nail in the horse the whole time. We'll try to make provisions, but it's really important. So my point for saying this is look in the bottom of the foot. Stones can get caught into the shoe. There's a lot of reasons why they can come up lame. So these 2 videos are going to go. I want you to see the one in the lower right-hand corner first. I'm going to move this one up a little bit. But the one in the lower right-hand corner, you're going to see this horse is very lame on his left front. You'll notice that his forearm is very, very swollen. It's not very swollen, but it's swollen enough. He's lame enough he doesn't want to walk on it. This story, if you can make it out, he's probably turned out with another horse, and this occurred with some altercation where he took a kick from the other horse. And this is the scary one, okay? This is the one that concerns all of us. And they're going to show you in a minute here what this horse has. And he actually has the bone underneath of this area has, in fact, a fracture. And these can show up just as a simple little nick or a cut that you don't think anything of, and they may not initially be that lame. But if they come up lame with just a small little cut, the skin cut is not what's going to cause them to be lame, okay? Now, this other horse, which looks like a rather robust quarter horse, is going to be taking some steps here, and he's going to look pretty sore with every step that he takes. And I got to tell you, in this video, they said he had laminitis with it, but when I look at this horse, he just looks he's lame in both front feet from what I can tell, or at least both front limbs. And I'm guessing he also looks lame in the hind as well. So, the most likely scenario in this case is, in fact, a laminitis episode. But, I don't want to jump to a diagnosis, but just in this case, think anybody could appreciate that this is not normal. Okay. So I mentioned before the radius and horses that have turned out with another horse and having, a dispute in the field for whatever that means. This is the horse's knee that you're seeing on the left-hand side. You can see a little gas pocket, which is indicative of a cut on the skin, which in this particular horse was a very small little nothing cut. But I think everybody can appreciate there's a black line coming through this radius. There's another little line right here. This is the same horse, but you can see the line a little bit better here. This is a radial fracture. And this particular bone does not break nicely. And this is a huge, huge concern because these are incomplete or stress fractures that can then become catastrophic fractures. And this is probably one of the more common fractures that necessitate euthanasia in these horses. And where we really have a problem with these horses is them getting up and getting down. It changes the forces and the load on the radius, and they'll actually break it getting up or even getting down for that matter. So with this particular horse, he's put in a stall and either tied or prevented from laying down for probably about 2 to 3 months before this heals. And I love to spend an entire day on fractures with you. There's reasons why this fracture is very difficult to repair in an adult horse and usually not successful. So we typically try to treat these conservatively without surgery. So my big point for saying that is when you have a little nothing cut on the inside of the forearm and this horse is lame, you do always worry about this fracture. Now, the next image I'm going to show you is a little bit more catastrophic, to say the least. And this is the more typical scenario that we often see as veterinarians. And you can see this horse took a kick, and there's no way of repairing this particular fracture. This horse was humanely destroyed. Again, this is the more common way that we see this particular leg fracture. And anybody who's in equine practice as a veterinarian experiences this maybe one every 2 years. Maybe sometimes you get a span of a couple a year, but hopefully it happens less often than you think. Now, this is another horse that actually took the same kick to the inside of the forearm area. You can see it's a little bit swollen here in the soft tissues. I think everybody can appreciate this divot. I always use this analogy like taking a hard-boiled egg and banging the egg on the countertop, and you get that kind of depression. Well, that's what happened with this bone. And I will say, if you look in these other images, this bone actually is a little dead piece of bone. And we did, this case is currently going on. We actually did just remove this fragment of bone, which that wasn't, I mean, that we waited to remove that. That's not my big concern. That bone had to come out at some point, but it's not urgent. My bigger concern is if you guys look here, there's a black line here. You can see a black line here. It's not projecting well on this image, but there's another black line. This horse still has an area of a fracture that could become a catastrophic fracture. So this horse we removed this bone a couple weeks ago now, and he's still standing in a straight stall and not allowed to lay down for a little bit because I think this is a weak part where this bone can then spiral up the leg as a fracture. So, you know, look, horses do silly things and bad things can happen. But, you know, hopefully you don't experience this that often. But when you do, I need you to kind of be a little bit more prepared and at least question. And I'd rather tell you there's no fracture than worry about if there is one. After these two videos, let's start with the one on the top left. And I want you to see, I mean, this horse looks really lame. He doesn't want to put weight on it. But what's interesting in both these horses, when you look at their demeanor, you're going to see the horse on top left is going to go up and go take a drink of water. The one on the bottom right, you're going to see in a minute, he's going to posture to urinate, and then he's going to take a couple of steps, and then he's going to put his head down and eat some grass. I've never seen a horse with a fractured leg ever want to do something like that. Okay, so the one thing that you want to take away from this is, all right, we all see that he's not putting weight on. He's quote unquote lame, but it doesn't seem to be painful. I mean, it looks ugly, but neither one of these horses are overly painful. And the reason is both these horses have nerve damage or some type of nerve paralysis that's not allowing them to completely extend the leg so they can bear weight on it. So they're basically tripoding around and just basically hopping over in the upper left, the left front, and then the lower right, the right front. All right, so just to throw that little curveball at you when you're looking at these and assessing these cases. Now, this horse, and thanks Dr. Martin for this video, this horse looks like we've had a few too many cocktails. We look a little bit lame that we're kind of falling to one side. If you also notice, the horse tends to kind of fall to the same side and even get a head tilt along the way. And while this may look like a lameness, this is not. This is actually a horse that's neurologic, and this horse came up acutely neurologic. And this horse actually has some neck arthritis and some underlying neurologic condition that's actually creating that. So just, again, to throw that little wrinkle on you so you kind of get an idea. All right, so I know you're probably like, well, let's talk more about each one of those cases. I'd love to, don't have the time. So what I want to take home on the lameness is, obviously we're worried about fractures, and there's a lot of fractures out there that we actually can repair and the horses don't have to be humanely destroyed. But I think you always have to worry about it. You have to use your power of observation. We have to look for those, and we have to try to limit those. If you come up with a horse that does have a fracture, we can deal with it. We have to stabilize the horse. We got to keep him calm. Call your veterinarian immediately. Don't take him for a walk. Don't go jogging him all over the place, see what it is. Let's rule out some options first before we go and make a silly decision there. Unfortunately, they can't verbally tell us when it hurts, so we have to kind of deduce some of the things. I usually tell people, you don't have to necessarily walk them around, just keep them still, and we'll get out there and look at them. All right, so unfortunately, that's all we're going to talk about lameness.
Question for the lameness section. Do you always have to open the foot to drain an abscess?
Great question. No. Sometimes we let it try to drain where it wants to come out itself. So that's why we'll soak the foot or put a poultice on them or ictamol to try to allow it to get softer and drain out on its own. Often when we try to go after the area, we typically are in the wrong spot, I find. Sometimes we get lucky and we hit the actual spot. And some of them will come out the coronary band. I've dug on the bottom of feet and to the point that I've hit the sensitive area, and then it pops out the coronary band like, a day later, and it didn't matter where I was digging on the bottom. It wasn't going in the right direction. And some people feel strongly about taking x-rays. I haven't found x-rays to be all that sensitive for abscesses. You do occasionally see a gas pocket on some abscesses, but not all of them.
Okay. I agree. I feel like if the abscess is not getting better, that's when I tend to want to take x-rays, but I wouldn't necessarily do that right away. All right, thank you.
Go ahead. This is where we're going to get into a bit more of the gory pictures, and I'll let you know when we get to those. So lacerations. First thing with the laceration, I kind of want to know is what created the laceration. And for instance, if it's wire or metal, those typically create very razor-like sharp cuts, whereas wood tends to be a little bit more destructive to the soft tissues. But my bigger concern with that is that it will create foreign bodies because wood likes to splinter. I'll show you a picture of that in a minute. Obviously, I'm concerned about when it hits blood vessels, and anybody who's been around a horse hemorrhaging, it's stressful, it's exciting, it's all emotions that you really don't want to experience with it. But there are ways we can get around that and handle those situations. Hopefully I'll give you a little bit of an idea. If we have an area that's over a joint, that's probably my bigger concern than even a laceration to a vessel. Depending on the depth of the laceration, what structures underneath the skin got involved, this is where I worry about stability of the leg and whether it hit tendons or ligaments, etc. So the first thing I ask most of my clients, as long as it's safe, and sometimes you need another set of hands with it, is to clip the area and get a real idea of what's going on. Now, if you've got hemorrhaging going on and you can't stop it, don't worry about clipping it. First thing is wrap the leg, assuming most of these areas are on the leg. If you have bleeding going on, wrap the leg. And if you have blood soaking straight through your wrap, put a second layer on and wrap it like there's no tomorrow. Don't worry about bowing a tendon. I'm not worried about this. It's not going to be a long-term thing. At this point, we're just trying to slow down the bleeding so that it actually will naturally clot, all right? And if you have 2 layers on and you still can't make any headway, that's when we start talking about a tourniquet. And I've talked through a couple clients in my career on putting a tourniquet, which they just use their belt. And again, these are temporary things. When we put tourniquets on legs for surgery, we keep it on for a couple hours, so you can effectively do that. Now, long-term with a tourniquet on, it does affect cell longevity and everything. But at this point, we're just trying to stop the bleeding so that a clot actually occurs. And obviously call the veterinarian. And so it's usually the lower leg, and these are just a couple of anatomy pictures from the fetlock down, giving an idea of the blood supply. The skin is actually thicker on the lower part of the leg, but it's surprising enough that the horses always seem to cut themselves right here on the pastern. And there's some major vessels that like to come down the pastern, and they love to hit those. I mean, they get them really well. particularly on the hind legs, I find, which, you know, you're trying to get to that area and it's kind of pointing the wrong direction for you. Anybody that's experienced these, they're exciting, they're stressful. This next image is, this is not even a fresh wound. This is about a day old, but this is the bottom of the horse's foot. His toe is down here to the lower left, and this is the front of his hoof. These are his heel bulbs. This is a front leg, and the horse clipped himself with his hind legs with a shoe, and he cut this heel bulb. And like I said, this is about a day old. This area doesn't bleed quite as much, but if he had gotten a little bit higher right in this area where these blood vessels are, then those are the ones that really like to bleed a lot. The next picture is a little bit gory. And so this is the one where we have a wood-related injury. The image on the right is not one of my images. Dr. Nicole Smith deserves credit on this. This is one of her horses, that not her own personal horse in her practice, that impaled himself on a piece of wood. Surprisingly enough, this went actually up into the armpit and not into the chest. Obviously, there's a fair bit of hemorrhaging going on. It's not terrible. There's really no way of wrapping this. They did actually a nice little job of putting a towel on there, and they shipped this horse to a referral center. The one thing to think about this, and it brings it home, and this is a completely different case, is Dr. Martin's hand with a wound that she was dealing with, that she pulled out this splinter. And when you think about this big block of wood, we're talking about multiple splinters that could actually be festering for several weeks and months, even despite the best surgical conditions in this case. So these add a little bit more complexity to how we deal with these. This is another horse that lacerated. This is a hind leg, and you're staring at you can't really tell, but the cannon bone's staring at you right there. He actually missed the joint, the tendon sheath. She missed the joint, the tendon sheath, and the vessels in this area. But you can see the leg's already swollen. This is only about, I'd say, less than an hour after the laceration. This was not a horse I was looking forward to stitching up. I've known this horse for several years. She doesn't like me, and she doesn't like her hind legs being touched to begin with. And so she actually did very well with this. I didn't curse at her at all on this time. But and I wanted to show you my stitch job. It's not my most prettiest stitch job, but I wanted to show you something a little bit different that you might not normally see in terms of stitching. Because the skin is so swollen and over the cannon bone, it's not very elastic, this skin. So getting it to cover and close is a challenge. So what I did in this case is these are little rubber tubings with my sutures to kind of pull that tissue together all along here. And it didn't want to come all the way together. And if you notice, there's a couple little slits in the skin over here and over on this side. So I made additional incisions to kind of make it a bit more meshy or lacy to basically stretch this skin so I can get it closed. Surprisingly enough, this healed. I actually had every expectation that this was going to fall apart, at least partially, but it actually stayed together and healed very well. She still has her opinions about me, but and some of you have seen my talks, have seen this picture multiple times. This is unfortunately an unfortunate laceration. This will heal very, very well no matter what, but this could have been prevented because there was human error. This is the scenario where you're taking a horse out to the field, you open up the gate and you decide to just let him run through and unclip him and not walk through the gate, turn him around like you're supposed to. And what happens is as they go running through, and it can happen with a stall door as well, if you don't keep these little door latches, they catch the area of tissue, and as they bolt through it, it rips apart. And that's the kind of laceration you get. Now, in this particular wound, I actually did not stitch this closed. Owners weren't very happy with me on this. We actually used the garden hose and ivory soap the next few weeks on this horse. And I just wanted to show you the power of healing with this. And these horses want to heal. And yes, this horse was turned out and he would lay in the mud and manure and everything else. And this horse did very, very well. You can see over the timeline of 5 weeks. This is probably another month down the road after that. And the nice part with horses from a cosmetic standpoint is they have hair that grows over and you don't see the scars. Now, obviously, this is not ideal in the human scenario in terms of scarring and cosmetics, but we get away with a lot more in our horses. This next horse is a horse Dr. Martin was dealing with. This is the front of a fetlock. And Dr. Martin saw this wound within probably an hour of it happening. She did everything she could and cleaned it up and stitched it up, and it looked absolutely gorgeous. And within a very short period of time, I don't know, probably about a week or so, it decided to fall apart. Maybe it was 2 weeks, Jess, or about a week? Okay.
Sorry. Yeah, it was probably within the first week.
Okay. The problem is with these front of the fetlock wounds is there's a lot of motion, and how these wounds occur is usually they fall on this area. So there's a lot of dirt and debris, road rash, in some cases of gravel can get caught in there. So even in the best of circumstances, getting them to heal up cleanly is always a challenge. So unfortunately, many of the stitches Dr. Martin put in all wound up coming out. And so then we're left with this open wound to heal, what we call by second intention, which this really shows a nice way of how it goes. And the images you're seeing, this is week 1, this is week 2, and this is week 3. And the images on the left side are the beginning of the week, and the images on the right are the second half of the week. What we also incorporated in this case, and when I say we, Dr. Martin, she not only immobilized this leg, but she also treated this with a class 4 laser. And this really does show how quickly this in fact heals. I mean, this is 3 weeks. And how quickly that closed. And it's really been quite remarkable, even in my impression, how nicely the laser will help in the right circumstances. Okay, and that's all we're going to talk about lacerations. Again,
I just have one question, 2 questions actually. Laurie Leifer wants to know, why did not infection occur in that wound with the big hip wound?
That's a great question.
Did you give an antibiotic for that?
I did not do antibiotics on that horse because my opinion, first of all, I think we overuse antibiotics personally, and I've always been trained to use the bare minimum that we need to. When you have a wound that's open and draining, I don't feel like you need to have antibiotics. Just like I don't typically put any of my abscesses, or at least hardly any of my foot abscesses, on antibiotics either. I don't think the horse needed it, and it didn't in that case. Now, I've shown that picture to other veterinarians, and there are other veterinarians have said to me they definitely would have put him on antibiotics. It didn't need it. Ivory soap and a garden hose was just enough.
And one other question from Deborah Clark: what creates proud flesh in these injuries?
Great. So proud flesh is something that horses are exquisitely good at making, and it's basically what we call granulation tissue. If I go back to this picture, basically this is proud flesh or granulation tissue in these areas. It's the normal phase of wound healing that we look for. The problem is horses can do it exuberantly. In fact, this one almost makes it look like here that you're getting this kind of mushroom-like appearance in here. And there are ways of combating it and bringing it down, but we actually want granulation tissue or proud flesh in these horses. We just don't want it to go, we don't want it to have a party. We just want to keep it to a dull roar. Okay, so this is eyes. I'll let you know when the gory picture comes up, and if you need to look away, that's fine. So first thing, I think my big take home on eyes is I think most eye injuries or issues are emergencies. I think people need to, unless this is a chronic condition that people are used to treating with on a particular horse, I do think they need to be seen when you first have them happen. Basically, when you look at a horse, they should have both eyes open. There shouldn't be discharge, so it should look normal, not abnormal. The lower left-hand picture, you can see this horse is squeezing his eyelid shut. He's got drainage coming out. He's got a little bit weird goopy stuff coming out, and you'd see the whole eye is quite swollen. The image on the right, you also have tearing going on. Some of you can see that there's a bit of a mass going on here on the third eyelid. That's not an acute thing. That's a chronic thing, and that's actually a tumor of the eye. But again, powers of observation of noticing the differences. I think it's really cool from an anatomical structure standpoint. The eye is a soft tissue structure that has tissues that are clear. I just think that's remarkable because light comes in from the outside here, comes through this clear cornea, goes through a fluid pouch, and then through another clear structure we call a lens, and then goes into another fluid and gel structure that then hits the back of the retina, and an electrical impulse then gets translated to the optic nerve and goes to the brain, and we visualize an image in our brain. So does the horse. I just think that's a cool thing, but nobody asked me. Anyway, one of our big concerns that we have with eye issues in horses is this surface called the cornea. And these horses like to get ulcers on there. They can lacerate these areas and get cloudy areas. And again, they need attention. You need to address them sooner rather than later. And even though the best of circumstances, we have negative consequences with those. So this is a normal eye, and this horse has actually went to the eye doctor and actually had his pupil dilated. So this is it's a normal eye, but it looks like he's been drinking too much or he's stoned. Just to give you a couple ideas, you can see upper eyelashes. Horses have a lot of upper eyelashes. Not all of them have lower eyelashes, and usually they're much finer. This is a blue-eyed horse. You can see the white and blue and a little bit darker blue. The pupil is quite large. These little kind of cluster that you see along here, this is called the corpora nigra, and that's a normal structure in the horse's eye. And this is also corpora nigra down here. It's just not as prominent. And why does the back of the eye or the retina look red in this case? Well, the light of this camera reflected off of the optic nerve, and you got a red eye. And that's what happens when you're at a cocktail party and you snap a picture of somebody and they get a reflection off their optic nerve. That's what gives them the red eye. Okay, so the next pictures are a little more gory. So this is a brown-eyed horse. You can see a little bit of black pigmentation. You see his iris. It's very brown. You have this cluster right here, what we call the corpora nigra. Notice that his pupil is much more constricted, and that's because the light that I'm shining in for this photograph is causing the pupil to constrict. All that part's normal. What you should be focused on is this area here on the cornea that has this big cloudy area, and there's this other area that looks like a divot. When we put a green stain on this eye and use a black light, you get this really cool fluorescence. And it's not cool for the horse because that's telling us that we actually have an ulcer on the cornea, and that's this area right here. I actually would have expected the stain to come up here, but it came up here. Now, if you look at these other images, this horse you can actually see, it's a little of a blurry image, but it still shows it really nicely. There's almost like a divot in the surface of the eye, the cornea, and then you have like a rim of fluid accumulation, which we call edema. This horse has an ulcer that takes up stain, and the stain is basically telling us how deep of a defect is in the cornea. All right, so basically a layer of the cornea, kind of like an onion, part of the layer came off of that. The image on the lower left-hand corner is just showing you a horse's eye that's very swollen, at least the eyelids. And you can see the conjunctiva, which is this pink tissue here, is really swollen and edematous, versus the horse in the lower right, this entire cornea has become very, very cloudy. And this is actually a glaucoma episode. The whites of the eye we call the sclera, and you can see that we have blood vessels coming down. This is a few more blood vessels than we would normally expect. This is quite irritated, as is the upper or the conjunctiva of the eyelid is pretty red and angry. So this is some chronic inflammation going on. And, you know, the tough part is horses can't verbalize to us. And there are eye conditions and certain diseases that we see in horses. They probably have lower level ocular pain, and we have no idea until we start having more serious ramifications and consequences of those. This is a paint horse, and I will openly admit that I doctored this image a little bit more. This horse actually did have some liver issues, but if you notice, the sclera of his eye is rather yellow. And just like in people with cirrhosis of the liver and secondary to alcoholism, you'll see that one of the things that happens is the membranes of the tissues, whether it's the gums or the sclera of the eyes, will become icteric or yellow in this case. This is probably not going to happen acutely, but it's something to be looking for, and again, your powers of observation. So my take home with eyes, and again, I've given you only a very brief introduction of that, is really don't ever relax with them. You really should have a veterinarian be looking at it and come up with what treatments and therapies can be there. And there are multiple different medical therapies out there. There are several different surgical options out there. And then there are a lot of horses out there that we've removed an eye, and they have very functional performance careers like that. Go ahead, Jess.
One question about eyes. I think it's referring to a corneal ulcer. Will this injury cause blindness?
So surprisingly enough, most of those ulcers will heal and they shrink down quite a bit. It depends on the progression that it goes. Certainly that area that's cloudy, they can't see through that, but that's a very small amount. And they will actually, most of those ones that we showed you in those pictures will heal back down to normal, and they won't have any visual impairment.
Susan Auer, I'm going to leave your question for the end. And if anybody has any other questions they think of, just feel free to add them here and we can go over them at the end.
Okay. All right, last little section. I didn't know where to put this in. I just thought this was a good thing to highlight on. And we only have 2 more slides here, so I know I'm already out of time. But allergies. Most of them are not really emergencies, at least the most of the allergies that we see. And so why does a horse get allergies? Well, no different than people. There are allergens, the environment for the most part. Horses are allergic. Some horses are allergic to hay and pollen and grasses and cobwebs. Kind of sucks because that's their entire lifespan there. Um, Bugs can cause allergies, certain ones, whether they be, mosquitoes versus bees, et cetera, and certainly some medications. And unfortunately, we all find that out the hard way. There really is no great way of testing on that until you actually experience it. And many of you have had horses or seen horses that develop these hives. And these are basically allergies. You see these all little raised areas. And what's happening in these cases are little blood vessels are breaking and you're getting these kind of